Afternoon. Welcome to our first Safe Every Day of this year. We can do it in 4 quarterly sessions, and the sessions will be advertised out there. We're going to have 3 presentations after Claudia's kind of relaunch session, and we'll be taking questions in the room. There will be a recording online on the gov.gg/Safe Every Day website in due course. Just take a few days to get that sorted out. And I'll just hand over to Claudia, who will just do a little introduction. Thanks, Claudia.
Great, thanks everyone. Hello, hi, good afternoon. My name is Claudia Megley and I'm Director of Quality, Safety, Improvement and Safeguarding. So it's an absolute pleasure to be here with you today for the relaunch of Safer Every Day. And I would like to start with a thank you. So I'd like to give a very warm thanks to Tammy, because without Tammy, our relaunch wouldn't be possible. So Tammy is our new Safer Everyday lead. And then I'd also like to thank Kelly, Joe, Elise and John, who have very generously given of their time today in order to create today's fantastic agenda. So what's new with Safer Every Day? So we've got a new look, a new format and a new approach. So Tammy and the team have put together a new look and a new format. So you might recall that Safer Every Day used to be monthly. It's changed. It's now quarterly. And in terms of the program is designed around different themes. So every quarter we're going to have a different theme that we're able to explore and deep dive into. And in terms of the approach, we've got a new approach because it's very much a co-productive approach. It's about Tammy and the team coming out, speaking with colleagues and finding out what's important to everyone within health and social care. And the aim of that is to ensure we have the right topics at the right time in order to ensure that learning is maximized, and we're talking about topics and themes and ideas that are really very relevant to you. And in terms of Safer Every Day is part of a wider strategic learning vision within quality assurance and patient safety. So Safer Every Day sits alongside 2 other initiatives, which is the Safeguarding Forum, which Joe Penny leads with Leslie Thackeray, so named nurse and designated nurse, and it specifically focuses on safeguarding for HSC, and it sits alongside the safeguarding webinars, which is broader, and it's for safeguarding across different service areas and ensuring that everyone has an opportunity to hear expert voices and new research in relation to safeguarding. So those are our 3 pillars of learning within patient safety and within quality assurance. So if you've not signed up for the other sessions or initiatives, please do, and please do sign up for further Safer Everyday sessions. So what is Safer Every Day? I'm sure a lot of people are really well versed in it, which is really excellent. For some people, it might feel like a newer approach, but I thought it might just be helpful to highlight what some of the key themes or what some of the key impacts we're hoping with in terms of Safer Every Day. So Safer Every Day supports a no-blame culture. So being a clinician, being a practitioner within health and social care, it's extremely demanding, it's challenging, it's also rewarding. And it's really important that we allow good practice to flourish. And in order to allow good practice to flourish, it's so important that we have a no-blame culture. And of course, blame relies on 2 myths. The first myth is about perfection, that if we just work hard enough, if we just try hard enough, we won't have any errors. The second myth is that if we punish people, they're not going to do it again. And of course they miss. Why? Because what we have to think about is we've got to think about the fact that we work within complex systems and that there are many factors that influence the likelihood of error. And therefore a systems approach to error considers all the relevant factors and it considers the system as a whole, and we need to invest in the system in order to ensure that we do the right thing at the right time. So it's not about individual error, instead it's about systems and how do we support good systems for good practice to flourish. Safer Everyday also supports networked learning, so it's an opportunity for people to come together, to network, and it's about relational learning. We learn better when we're with others. We learn better when we connect with others and connect with the material that they're sharing. So Safer Everyday allows us to network, and it allows us to think not just about the information or about what's being communicated. It also allows us to have a relational stance to the work that's being shared. Safer Everyday also supports psychological safety. It creates a space where people are able to share ideas, experiences, good practice, as well as things that maybe didn't go to plan. It's a place where we can learn and share together without judgment, which is so important. And research highlights that organizations that do psychological safety well results in higher retention for staff, as well as better outcomes for patients and service users. And that is so crucially important. Safer Everyday is also a really important part of our quality assurance cycle, as well as our continuous learning and improvement. So a lot of the topics that Tammy would have chosen for today would be things that have arisen through audit, or things that have arisen through data or complaints or compliments. So Safer Everyday not only supports continuous learning and improvement, but it's also evidence-based. What do we need to learn? Learning the right thing at the right time, if you wish. There's lots of other really positive reasons for why Safer Everyday works and why we should invest in it as an organization. And if you're a manager, to encourage your staff to attend. I'm not going to go through all of that because I'm sure that you will be able to review it in your own time. And of course, I'd like us to get on to our wonderful guest speakers who have very generously given of their time today. So I hope that you have a wonderful session with Tammy and the team, and a great thanks again to Tammy as well as our guest speakers. So Tammy, over to you. Thank you.
Thank you, Claudia. So Claudia, I didn't introduce you before. Just don't tell everyone your job title, because we didn't. Some people might not know who you are.
So I said it at the start. It is a bit of a tongue twister. So it's Director of Quality Safety Improvement and Safeguarding. So my role is about patient safety as well as safeguarding and improvement, and it sits not just within health and social care, it actually sits across all the 4 key committees. So it means that my role and my remit is multi-agency. So in that sense, a bit of a unique role, because usually individuals work to one specific committee, whereas I work across different committees. In terms of my role, it's important that my role has independence and that my role is a critical friend. So due to that, I report directly to the CEO and head of public service to ensure that I'm able to be a critical friend for States of Guernsey, and of course to have the pleasure of working with all of you fabulous people, as well as working very closely with Steve Winterflood as head of governance and patient safety, as well as the patient safety team, who, I'm biased in my view, are fantastic and fabulous, as you can see. So thank you very much, colleagues.
Thanks,
Thank you.
Claudia. I'll just take your mic off you. Yes, of course. Thanks very much. So we've got next presentation by Kelly. After Kelly, we'll have just a 5-minute time to get a cup of tea or whatever, and for the people to sign the register afterwards. So Kelly is our preventative care practitioner, and we'd like to talk to you about what she's been doing in her role. So it's just to click forward, and that's to go back, and I'll just pop this on you, if that's all right.
Lovely, jolly good. I'm really good at yelling, so if I'm shouting down the microphone, please let me know. I always get a little bit nervous because I can normally speak without needing a microphone, so let me know if I'm yelling at you all and I'll try and quieten down a little bit. So as the slide suggests there, my name is Kelly. The presentation is entitled Cake and Consultation. That's a little project that I do as part of my job role. One of those things that started as a side project and very quickly became about 90% of my job role. One of those things where you think, oh, I've got a nice little idea to pass a bit of time that snowballs into something that you weren't expecting. So I'm going to talk a little bit about that as well. But to start off with, I'm just going to give you a little bit of an oversight of my professional background, just so that you can kind of get a feel for what I am and what I do. So I started my career as an occupational therapist, and I worked in the Qatar Hospital in adult community services, where I did a timeshare job role. So I did 50% of my time with the community services team, and I did 50% of my time with the rapid response team. And I did that for a few years before moving over to the ambulance service, where I started on the frontline ambulances and then became a paramedic. And I worked on the front line for nearly 13 years before moving into this role, where I've done a full circle and I've ended up back in the same office at the Qatar Hospital, albeit it looks a little bit nicer than it did 19 years ago when I started off there in the first place. And what's lovely about my role in preventative care is that it's a really lovely mixture between my OT hat and my paramedic hat. So there's plenty of involvement with the holistic patient, the person as a whole, the environmental factors, people's ability to function throughout their day-to-day life, and their safety and security at home. And there's also a lovely bit of intervention where sometimes when we go and visit people and they're not as well as we would expect them to be, I've got that lovely medical side that I can put that hat on and deal with quite a few problems that people have all at the same time. So I can imagine that most of you in this room will have heard of preventative care and will have talked about preventative care in various roles, but what we're looking at is things that are preventing disease, injury and illness. And what we want to do is take steps so that our health and our patients' health stays at a good level, rather than having to tackle with issues and deal with issues afterwards. We're also looking at how us as a healthcare system can predict problems before they appear or diagnose them early so that we're dealing with them while they're in their infancy. And there's lots and lots of different ways that we're doing that, lots of different ways that Guernsey's doing that as a whole. What we want to do is do whatever's in our power to keep our health at a good level, regardless of our age and ability. It is a myth that everybody struggles as they get older. Naturally, there are some diseases and some conditions that get a little bit worse with age, but it's not the case for everything. And it's important to find that balance between what is a natural part of the ageing process versus something that is treatable and we should be doing something about. And why does it matter? Why are we trying to explore preventative care measures? Quite simply, it reduces pressure on the healthcare system. So it's more chance of a speedy appointment and more chance of a quicker course of action. Less pressure on acute healthcare systems means less people waiting for appointments, treatments and hospital stays, which means easier access for those at the point of need, and resources are directed appropriately. So the preventative care practitioner role moved to health and social care in April 2024. So we're coming up to a year with it being a HSC post, and it is run autonomously. So I am a sole practitioner, but luckily I've got good wider team networks around me. So all of the teams within community service I can access for support and advice if I need to. And the aim of my job is to provide clinical assessments which hopefully improve the lives of older people. So my patient age range tends to start at around 80, so often dealing with our much older population. So referrals come to me through a variety of formats, but the main two here are through St John's Ambulance Service. So there's a direct pathway from St John into community services and into my service. So if they, for example, have visited somebody at home that doesn't require an ED admission, then they don't need to go up to the hospital. Previously, that's where the pathway kind of tended to end, whereas now if the crew are on scene and thinking, well, this person isn't medically unwell enough to need to go to hospital, but actually there's a non-emergency issue that needs to be dealt with here, they can access me and I will go out and review the patient as a whole in their own setting. Now, cake and consultation, we've mentioned that already. This was my little side project that snowballed into becoming most of my job. And this was an idea that was set up following an injection of money from the Insurance Corporation bursary. Some of you might have heard of it before, and if you haven't heard of it, it normally happens around October time, so look into it because it could literally change your entire career. So I applied for a bursary through there and was lucky enough to be successful, and Cake and Consultation was born. And the idea behind that is that invitations are sent out for assessments. So it's based on people's age. So at the age of 80, 85, 90, and then every year following that, people get a letter in the post that invites them to book in for an appointment with me. And then I go round and we have a lovely chat about how they're getting on at home and how they're managing. And my assessment is split into lots of different areas. So we talk about personal care, we talk about mobility, we talk about environmental issues, we talk about slips, trips and falls risks, we talk about adequate hydration and nutrition and a little bit of everything. So it's a bit of a whistle-stop tour of somebody's world at home, really. And the idea is that we're finding problems while they're hopefully still little. Most of the people that I see, because we're approaching them and we're reaching out to them, and I keep saying we, there is only me, when I'm reaching out to them, they're not all known to community services, so they don't have packages of care. They're not known to the ambulance service necessarily. They're not necessarily visiting their doctor on a regular basis. So it's a nice way of reaching out to those people that aren't already involved, don't already have a system of care. And what I want to do, I've just said that bit. What I want to do is help them to navigate our service, because all healthcare services can be a little bit complicated. We all wear a different uniform. We all come with a different team. You often see a different person every day and things like that. So I understand why it can be complex for them. And often people are put off seeking help either by the cost of that or because they simply don't know where to go. So trying to help somebody navigate which service they require, or equally which charity they might benefit from, which States department they need to speak to help deal with whatever issues they've got. If I can't deal with a problem, then I've got great links through community services that I can link through to other specialist services that can hopefully help either me answer the question on somebody's behalf, or I can do a referral through to specialist services there. And a little stat for you there, last year an average of 76% of my patients received some sort of intervention, which again, bearing in mind these people aren't previously known to services, to have that kind of intervention rate where something's being fixed, something's being resolved, we're planning for the future, we're being proactive, is hopefully going to start showing benefits in time to come. One of the other things I do, one of the most favourite parts of my job, is I go round to social groups, so places like WI, Age Concern, Alzheimer's Society, the Guernsey Wives Club, you know, these sorts of establishments, and do little presentations, whether it's an introduction to my role and how you can access the service. We look at falls prevention advice, how to avoid slips, trips and falls, what to do if you do fall. And also I've just introduced another one, which is how to make an effective 999 call, how to get that emergency help to you as quickly and effectively as possible. And that's had some really good rates as well. I get a lot of referrals through people saying, oh, I could do that, or my neighbour could do with that, or my mum could do with that, that sort of thing. So all very positive. Had a recent expansion to the service, so like most services, when you set up, there's an awful lot of time spent organising the policies and the procedures and the paperwork and the assessment tools and what you're going to do and who you're going to work with and trying to get word out and things like that. So now that the job role is a little bit more established, we've been able to expand it, which is lovely. So we're seeing more and more people being offered support and more people coming into the service and what I call having the problems nipped in the bud and getting things sorted, which is lovely. So that's kind of me in a nutshell, really, and what I'm trying to achieve. I know there's a few faces in the room that I'm familiar with, some people that I know, some people that I've worked with, either in this role or in previous roles. But I'm fairly open to telephone calls, emails, questions and things like that. So if anybody's got any particularly that they want to ask me now whilst I'm being recorded in a room full of people staring at me, you know, feel free. Yeah.
I do. Hello. I'm Jenny Ventura. I'm the Clinical Audit and Quality Manager
Hi.
for HSE.
Hi.
I'd like to praise you for the amazing work you are clearly doing.
Thank you.
And how dynamic you are, because this kind of work does need a person like that, so well done.
Thank you.
Preventative care is quite close to my heart, having worked in it and health promotion alongside for more than 14 years in another jurisdiction. So I was listening to all you're doing and thinking, how close do you work with public health? Because you mentioned adult community services and the wider team that supports you. And we've heard Dr. Brink raising all of these concerns you just shared with us.
Yeah.
So how close do you work with them and how aware are they of the data I'm quite sure you are remarkably producing?
The simple answer to that is not yet. So it's in the pipeline, coming soon, on my to-do list, branching out and seeing how we can make it a more effective, wider branch, because with all job roles, when you are a sole practitioner, it's very, very difficult to kind of branch out and find out not only how to get people into me, but equally where to take them afterwards if it's something that's more than that quick fix. So yeah, it's definitely something that's on the imminent to-do list for this quarter.
Good. Perfect. Thank you. Mine hopefully is quite an easy one. I'm Claire, one of the quality improvement managers. I mean, I think I was struck listening to this how clearly needed it is a service. Would your aspiration be that it's something that can grow? I appreciate resources are limited, but undoubtedly there is evidence of the resources you're saving by doing so. So is that what you would envisage as
I would
overall?
love to have a team of people behind me. So again, as you said, it's resources, isn't it? It's money. I hope that once we've got enough stats and data behind us, because obviously it's really difficult when it's a new job role. There's often a little influx, a little flurry of excitement at the start, and then it might peter down, it might get so much. At the moment, the reason the age ranges are the age ranges that they are is me trying to find a sweet spot between getting the word out, letting people know that there are services available and that there are things should they need, versus having so many people on my caseload that I'm not able to go and see them because I've got a 6-month waiting list, which then isn't proactive preventative care. It then becomes reactionary care because we're just dealing with the urgent and the issues. So the answer is it would be totally easy to expand. The question is, how do we expand it? And I've thought long and hard, of what that would look like. Would it look like somebody else like me, so we can simply double the amount of assessments that we're doing? Would it look like nursing background, therapy background? Would it look like admin support? Would it look like project manager support, to do all of these things that I've had a very steep learning curve for in the time that I've been in this job role, simply because having come from a purely clinical background, things like setting up a project, you think it's quite easy, don't you? And then you have a little taste of reality. So absolutely would love a team behind me. It would be a very easy, this is how we do it and this is what we want to do. Like everything, it's the money. It's the money behind it. So fingers crossed, when we've got enough stats to prove that actually this little injection of cash is saving that much, hopefully then we can justify it.
How are you measuring, what is your indicator that you are saving money?
So at the moment, what we're looking at is so my interventions are split into different categories. So we're looking at things like whether people are given bits of equipment, and some of the things are very difficult to quantify. So for example, falls, it's very difficult to say, well, that person will never have another fall because I've given them this piece of equipment. We can't do that. We don't know whether somebody has been prevented from having a fall because, apart from things like how often they're then calling ambulances out or how often they're going back to the doctor and doing things like that. So at the moment, it's based very much on those sort of little quick fixes and how much time we're having versus the proposed benefit. One of the other things that we're looking at, which hopefully will be a little bit easier to put in statistical format is a project that I've been doing with some of the care homes with regards to emergency lifting equipment. So if they have a resident that falls over but is uninjured, I've now given them the training, the equipment and the confidence to be able to deal with that, following a particular algorithm that was created by South West Ambulance Service, that somebody, whether they're clinically trained or not, can work through this algorithm with the person that's on the floor to determine whether they need to call an ambulance or whether they can be safely lifted off the floor. So that's the kind of thing that, again, with time, we're going to be able to see, because we're going to be able to say, well, how many times have you needed an ambulance for this person? Or how many times have you used this without having to call the ambulance, which in turn costs an ED admission, which potentially costs a ward admission. So things like that will become a little bit easier. The other thing that I've been really lucky to have is a lot of positive feedback, which I know those of you that deal with money and accounting, positive feedback maybe isn't the easiest way of sort of showing success, but the feedback that we're getting from homes, from relatives, from patients is just really lovely. And I think that's one thing that I'm doing a report at the moment, that actually I'm pulling some of these quotes from people, because sometimes you could look at a stat and say, oh, I saw one person this morning, but actually the bigger picture is, well, that person might have taken me 5 hours to sort out, and actually that person's life might be so much better now. So some of it is quite difficult to quantify, but other bits hopefully we can do as time progresses.
Do you think there might be a possibility for like a £25 charge for it? Or do you think that isn't something that we should go down? It should be.
I'm not sure I'd get the same engagement.
What do you know? What percentage? I appreciate you've not got a year's figures, but of the invitations you send out, how many accept them or how many reject them?
Yep. Now you've put me on the spot without my laptop in front of me. I do have those figures, and it's positive. It's something around something like 26% rate of return, which I thought was really rubbish, but then somebody told me anything above 5% is pretty promising with regards to engagement in surveys and things.
Oh, really?
Yeah.
So it's not the majority take you up on it?
No, so I do have a criteria. So when the letters go out, I don't see people in nursing homes or residential homes or extra care housing. And I don't see people that have got full packages of care, because they're already the people that are being dealt with and they've got their links and they've got their contacts. I also have a way of monitoring, say, for example, somebody's known to the palliative care team and it wouldn't be appropriate for me to get involved. So again, it's difficult to sort of, when you're sort of just going on age and then those sort of set criteria, the aim is to lure them in, so to speak. And I think if we gave a charge, that would put a lot of people off going for help, getting the advice.
Where do you get your information for the list from? You know, thinking about data protection and everything.
So from HSC's Track Care database with all the relevant permissions.
Right, so they have to be on track to begin with.
Yeah.
Just interesting.
Jolly good.
Hi Kelly, can I ask something? There's so many questions. That was an excellent presentation, by the way. Thank you so much.
Thank you.
So the St John's referrals, how many do you think you've had in the year or since you started?
So initially there was again that flurry, and then what I've done now is I've separated it. So now, rather than just directly referring to me, they're able to refer to community services as a whole. So the referrals come in and then they're split down. So me personally, not as many as I would like. It's one of those engagement processes where initially the feedback that I was getting was that the referral form was too complicated, and when they've already got lots of other paperwork, so simplified that, and now it's a checkbox. There are criteria that I am trying to encourage them to utilise more. So for example, if somebody's had a long lie, they should be being referred to me, but they're not always referred to me. But as I say, now some of those numbers are split because they would go to the generic community allocations meeting, and if it was deemed that a different team was more appropriate, they might go directly there instead.
And there may be people who aren't on track as well. So you're
Yeah.
picking up through that process, but I just wasn't aware that was a referral possibility. And the reason I'm particularly asking is I've got an interest in care coordination and the navigator role in the community.
Yeah.
Not a professional interest, but I did look at it some years ago, and I know we're missing a trick of the amount of care coordination that goes on. So multiple appointment booking and clinic booking for one person on the same day would save HSC
Yeah.
probably an awful lot of money. So I think it's worth pushing forward on the business case for more staff in your team, because care coordination is really important for this island as
Yeah,
we're getting on.
definitely. Fab.
Are there,
Really a question, by the way.
are there equivalent roles like this in the UK?
Yes. Yeah.
And they found them to be really, really successful.
I presume so, given that the roles are still there. Fab.
Do you get referrals from ED, or ED aware of you?
So ED are aware of me, but there's a lovely lady sitting at the back of the room called Emily, who's an OT that deals with the referrals that come through ED. So when I started my job role, Emily and I worked quite closely together, but what we found is that the ED referrals were often being duplicated, and we were doubling up and they were going to Emily and to me. So we sat down and worked out, actually, it's better if the non-ED ones come to me and the ED ones go directly to Emily. And then if there's any that we're not sure about, we phone each other up and say, I've had this referral, but actually I think it's more for you, or I think it's more for this, and we discuss it. So yeah, at the start, there was a definite role in there. But as I say, now it just felt like a little bit like we were not stepping on each other's toes, because that makes it sound negative, but the referrals were being duplicated, which wasn't helpful. So we've sort of worked out amongst ourselves which way the referrals should go.
I was just thinking, like you said that sometimes the long lines, you
Yeah.
not getting to
Yeah.
the ambulance service, thinking, was that another way
Yeah.
that you could have picked them up if ED
Yeah.
were kind of, like a check to see
Yeah.
if they were referred to you. But really good, like brilliant service.
Fab. Thank
Any
you.
other questions for Kelly?
It's my time in the Dragon's Den over.
I think it's really great actually to see. Thank you, Kelly. It's really. I think like the whole point of an event like this is to really showcase stuff like that, because I know from when I worked in acute, I wouldn't have had a clue about what someone was doing. So it's probably a bit of an eye opener for a lot of people, knowing that these roles exist and like how much it can kind of decrease pressure on the system. So thank you very much.
You're welcome.
Thanks.
Do you really give cake out?
Sorry?
Do you really take cake
Yeah.
to them?
Yeah, I take them a little fairy cake. Again, part of the lure.
Yeah,
It
brilliant.
was everybody like,
Thanks, Kelly. Thank you. What we'll do now is we'll just have a 5-minute break to just get tea, coffee and sign the register if you haven't done already, and then we'll have Jo and Elisa's session. Thanks. Okay, everyone, if you're all ready. Thank you. If we're ready, we're going to start the next session, which is Jo and Elise, who will introduce themselves, and it's about safeguarding the bailiwick of Guernsey. So thank you, ladies.
Right. So I'm Jo Penny. I'm currently the safeguarding named nurse within HSC.
And I'm Elise Bro. I'm the multi-agency safeguarding training coordinator for the Island Safeguarding Children and Adult Partnerships. Very long.
And we're just quickly going to go through what our roles are and how we've been working together on different things. So, what do I do as the safeguarding named nurse? Well, I offer advice, support and guidance within HSC regarding safeguarding concerns. So if anyone within HSC has a safeguarding question and concern that they want to discuss, they can give me a ring, come and see me, email me. I try and have 2 drop-in sessions a week so that I've always got access in my calendar, so that I can see you hopefully within a couple of days of you emailing me, unless it's really, really urgent. And if it's really urgent, then I try and talk to you as soon as I can. I try and ensure that safeguarding training is in place for HSC and staff understand what their safeguarding responsibilities are towards that. And I'll go into detail on a little bit more soon. I offer safeguarding supervision for staff as well. So I supervise certain staff around their safeguarding requirements, activities that they've been doing, and just make sure that they're comfortable in their roles. I complete some safeguarding audits, and I'm based within the hospital.
So there is an additional bit that I'll just talk you through. So what we have is the Island Safeguarding Children Partnership. That's embedded in our Children, Guernsey and Alderney law, so we are created as part of that. That has been going for a lot longer than our adult partnership. What we realised is that we also needed adult partnership for the equivalent oversight and to work on improving safeguarding and training available for everybody working within that area. We were originally called the Islands Child Protection Committee, so you might know us by that name, but we very much are moving towards Island Safeguarding Children Partnership. It's a multi-agency committee with people from the voluntary sectors. We have lots of people within the states as well, so we try and use a multi-agency collaborative approach to safeguarding. Its main purpose is to enhance the safety of children and young people in the islands through promoting effective coordination and cooperation between agencies providing services to children and families. The equivalent is the adult partnership, and the ethos behind that is exactly the same. What I personally do is slightly different to what the partnership does. So I very much focus on the training side of it. So I develop and deliver a lot of our training. And what we have is training that is best practice, training that can be part of your mandatory to roll package. We also have training which is developed as a result of emerging concerns. That can be both nationally, wider afield, and also locally. So we try and respond really quickly to any concerns so that everybody who comes across issues are as skilled as possible and know exactly what to do if they come across them. We have a pool of facilitators who support us because there's no way that one person could deliver all of the training. So we have people from lots of different services, teams, organisations and so on who come on board to deliver specific training, areas that they're particularly skilled or interested in. So you might see lots of them also delivering training if you go on it. So our Island Safeguarding Children Partnership, we're just going to go through a couple of headlines. I think there's, whenever I talk about who I work for, there are some questions. People aren't quite sure where we fit. So just to give a brief overview, the Island Safeguarding Children Partnership coordinate what is done by each agency represented on that committee for the purpose of safeguarding and promoting the welfare of children. Again, we promote effective cooperation and coordination for those involved in safeguarding children. Provide appropriate guidance, so we look at lots of policies that we then disseminate widely. So things like Child Not Brought, we talk about the processes, the procedures that people should follow and how those can be embedded across the island. We also review any case or incident where a child has died or suffered serious harm, and we come on to talk a little bit about rapid reviews and swarms a little bit later on. But essentially, if a child comes to harm or if they die, we can be involved in that review process so that we can become very quickly and do a rapid review, which is a very quick turnaround, or we can do a serious case review. Fortunately, Guernsey doesn't have many of those. I think the last one was in 2023. Just to look at what happened, why did it happen, can we make sure that we're all working together to stop it happening again? So the focus is very much on learning. Our adult partnership, safeguarding adults at risk of abuse or neglect by having in place policies, procedures, safe working practices, and suitably trained staff and volunteers. So I'll go on and talk about all the training that we offer and the training that we're developing. Like I said, the adult partnership is much newer than the children's partnership, which is quite established and we're embedded in law. Whereas our adult partnership, we're very much trying to grow and develop and look about the needs of the island and how we can support those. Coordinate multi-agency safeguarding adult arrangements. Again, we've got to provide appropriate guidance, so that can be policies, practice, reviews, etc. And review serious adult safeguarding incidents. So it's very similar to how we respond to children incidents. We try and look at what learning is available and try and make sure we're all working together to prevent something happening again.
So I mentioned about the training, because that's part of my remit of an HSE, is to make sure we've got safeguarding training embedded. At the moment, we are trying to write our HSE safeguarding training framework, which still needs to be approved. But hopefully when that is, it will really clarify what staff need what training and what type of training and where we will get that training from. So it'll be really, really clear for all different staff groups. But at the moment, there is mandatory training for safeguarding within the states of Guernsey that have come out, and that's your basic awareness courses such as your level 1 safeguarding adults and your level 1 safeguarding children and young people. And there might be other mandatory training that are linked to safeguarding that are specific to roles as well. Within HSE, as Elisa said, you know, there are various different specific courses that are developed in response to gaps in knowledge and to highlight new learning and best practice. And we're trying to use the safeguarding forum in that as well, to try and respond to emerging safeguarding concerns that are coming in areas. And we are developing more courses at the moment, including we're redoing the level 3 safeguarding course, which is in line with this intercollegiate guidance that is for HSE professionals. And the intercollegiate guidance is Guidance that's come from the UK, is used and embedded in the UK, and it's lots of different colleges, so it's like the RCN, occupational therapies, everything has come together and written these guidelines to say what training people should have for safeguarding, what content, how much should they have, how many refreshers they should have, and that is the guidance we are going off in Guernsey. Liz Thackeray has previously provided the level 3 as safeguarding named nurse. While we've been writing the framework, we sort of paused that because we knew Elise, as the training coordinator for the partnerships, was providing a certain level of the training we needed so that we could really refresh it and make sure that we had robust systems in place.
So in terms of what Joe's just said, these are the courses that we're currently running. We have some courses that we've run previously, but we're not running this year. Some are license limited, so we have a certain amount of time we have to deliver them over. But these are the ones that are on our programme for this year. So hopefully our programme will slowly filter down to everybody because we've issued that and it's got all of the dates for the whole year and all of the booking explanation. So we've got our basic ones, which are our level 2 and level 3 safeguarding children. Our ISCP is different to the one that Joe's creating because Joe's is specific to medical professionals, whereas our level 3 is appropriate for everyone across the island from multi-agency.
Just to add on to that, the level 3 I am doing is going to be very much your introduction to that level 3, whereas if you go on Elise's children's at the moment, it then goes into more in depth. So I might explain a bit about your children's MASH and your processes, whereas Elise will go into detail about what to expect in a conference.
Mm-hmm. Yeah. We've got our role of the convener and the CYCT. That's another thing which is quite specific to Guernsey. It can be very confusing for people coming over. They don't know how it fits. They don't know what the expectations are. They don't know why they need to care about it as such. So that course is very much looking at the law that means that the convener is something that we need to follow, the referral criteria, what that looks like, why it's beneficial to children, and so on. So for a complex area of law, it's well worth going on that if you ever need to attend a tribunal or anything. Safeguarding children with disabilities. Our children with disabilities are one of the most vulnerable categories. They are much higher risk in terms of chances that they will be abused at some point during their lifetime. So we've got a very specific course on that. We talk about neglect. So we know that there has been the neglect strategy in the last couple of years. We are very clearly focusing on understanding the long-term impact of neglect on children. I think it's hard to evidence, but I think it has some of the worst outcomes for the young people that I've worked with. So we're trying to very much skill people up to know, why is neglect so harmful? What does it matter if a child isn't cleaning their teeth and so on? So please look at that one. Disguise compliance is one that we see a lot. So that's normally where families, but sometimes young people, look like they're working with you, but actually you're not making any progress. So you're very much stuck. They're saying the right things, but you're not seeing any change. It's a really complicated area to work with, and identifying it and responding to disguise compliance can be a real challenge, but I've seen it in all areas that I've worked at across the States. So again, focusing on that, harmful sexual behaviour is where children, so those under the age of 18, display harmful sexual behaviour to themselves or others. We are looking at that very carefully. What we don't want to do is label children as perpetrators or abusers, because that label will stay with them forever. But we're trying to look at the reason that they're displaying that behaviour. And for lots of children, the research suggests that they've been subjected to abuse themselves. So we're trying to change that narrative and try and do the early indicators so that we're not having that harm being caused to other children. Safeguarding supervision skills. This is multi-agency. Hopefully people have access to safeguarding supervision, and Joe's going to be we're working together on this one to make sure that there's a model so that everyone feels safe in their practice, safe in their learning, and are able to reflect on their own needs and their own well-being alongside that of the patients that they're working for and the service users. Graded care profile 2, 2 different courses, fits very much into neglect. Neglect is quite subjective. You could all go to the same house. Some of you would think it's fine, some of you would think it's not okay. We're trying to take away that subjectivity, so we've got a really researched model and tool that we use from the UK, which is the Graded Care Profile 2, and it just helps guide you through, is this acceptable is it not acceptable, without bringing in your personal experiences. Early help assessments and team around the family is newer. That's related to MASH, so the Multi-Agency Support Hub. If they have referrals which have lower indicators of need, so kind of levels 1 or 2, then they might divert families off to early help, hoping that if they put their support in as soon as possible, it will stop those situations from escalating and becoming more concerning. And team around the family, lots of you might know the term team around the child. This is the model that we're using now. It just helps look more holistically at the family and all of their needs. So again, that's something new which is coming in. Hidden sentence, we are nearly there. Hidden sentence is for looking at the impact of parents or other close family members going to prison. So it's run in the prison. Prisoners do attend the training to support learning. It's run by Melissa Gill and Sarah Cross. Sarah Cross is the psychotherapist in the prison, and Melissa Gill works for education. And it looks at the impact on the child of having a parent who goes to prison, the stigma, how that might affect the parent being able to parent that child, and look very much at how we can support children who are going through that situation. And then our level 1 safeguarding adults at risk. So lots of you who work in HSC may well have done the e-learning. It's that, but in a classroom form for multi-agency. So that's all of the ones we currently do, which I think is quite a lot for a little island. However, I know, I'm not going to go through these in as much detail. What I said to you is that our adult partnership is much newer, and we are trying to bring our range of courses that are related to adults up. We're also trying to look at courses which can span the child-adult divide. We find that there's a lot of people who work just with adults, just with children, and there's a void in the middle. What we want is to develop courses where we can get professionals who work predominantly with the adult and predominantly with the child to work together and to use that training as a way of understanding how each other's service works. These are the courses that we've got in the process of being developed. We're hoping that most of them will be available kind of mid this year, and as soon as they're rolled out, we'll put out some flyers that people are aware. Self-neglect and hoarding are really important. I've worked with older adults, I've worked in the community, and the amount of hoarding on the island and the difficulties in challenging that and tackling that is massive and can be a huge health and safety risk. Capacity and best interests, we've got PPOT, which is person in position of trust, making safeguarding personal, and then we can just go through all of the other ones. The last two are ones which we're also trying to do in line with adult mental health, because they are diagnosable kind of mental health conditions in there, and we need to have more awareness of the impact of those while not stigmatising the adults who are suffering from those. So parental mental health and fabricated induced illnesses and perplexing presentations. So we talk quite a bit about the mental health needs of the parents, which can lead to the children having unnecessary procedures and being put more at risk because of that person's needs. So I think there's a challenge in understanding what that looks like. There's a lot of stigma attached to that as well. And there's also been quite a few cases in the media relatively recently as well, with specifically looking at that fabricated induced illness. Anyone who works with children or adults knows that no one fits inside a box, so we can get lots of really concerning factors that we're not quite sure what to do with. So we're hoping that that kind of perplexing presentation will also be able to help skill people, help them understand the recent research, the ways of working with families. So yeah, that's this year. We'll see what next year brings as well. It's a lot for me to talk about.
Yeah, it's great. I just grabbed the clicker.
We also do, I regret that, an annual themed conference with different guest speakers. So we didn't have one last year. I know it says annual, we missed the mark on that one. But we're trying to look at a really good theme, and that involves getting guest speakers over so that people can attend. All of our training is free. We don't charge for anything that we do because our ethos is that we are trying to make it as accessible for people in charities, third sectors, childminders, small businesses and so on to attend. We're also looking at our learning network events, and sometimes those can be small seminars. That can be where we disseminate the highlights of a particular report. If you want to book on our training, if you're within the States of Guernsey, you can book on your SAP or My Learning page. If people are outside of the States of Guernsey, they can either email me or thelearning@gov.gg. If anyone has any questions about anything that we do, please feel free to get in touch and I can give you more detail. I can send you our programme and I can book you on as well if you're interested.
and it is me now. So Elise has touched on safeguarding supervision training. We are delivering that together this year. I don't know the dates. I'm sure Elise will have them somewhere. And the idea of that is within HSC, a bit like with Kelly earlier, as a single practitioner, I can't provide all your safeguarding supervision. So it's about making sure our staff are skilled up enough to have that process within their areas themselves, so that there are group safeguarding supervision, or you've got your hierarchy and you know who to go to for the different safeguarding supervision, which is very different to your normal clinical or managerial supervision. It's got a different feel to it. So if you are interested in finding out more about safeguarding supervision and doing the training, please let us know and we can let you know the dates and when it's going to happen. It is a 2-day course. I actually did it a little while ago, and even just for a refresher on your general supervision skills, it's really, really good, and it's transferable to when you're doing other types of supervision as well. So although it is focused on your safeguarding, it is a really good course if you are doing supervision, other types of supervision in your general jobs as well. A bit about the other things that we are doing. So we've got our Safeguarding Quarterly Forum. Gareth Kidd, who is the business manager for the partnerships, such a job title. He is going to be at the next one in April, and he's going to give a bit of an update about more of what the partnership are doing, what they've achieved, and what their future plans are. There is a self-neglect task and finish. So Elise was speaking about neglect, self-neglect and hoarding. There is a task and finish that is running at the moment, multi-agency, linked to the partnership, that are going to look at the processes and pathways within Guernsey and the bailiwick to see what we've got in place. I've got a safeguarding newsletter that's going to hopefully come out every couple of months, so you all know of the different things that are happening with safeguarding. I'm involved in like the child deaf process, child deaf overview panel, and those parts. Rapid reviews and swarms, I wanted to put that in because I think there is sometimes not a great understanding of what the difference is. I think within HSC we're really great at knowing swarms because lots of people know how to request them, know what they are, understand them, whereas rapid reviews are a little bit more to the side and we don't really know what they do. Rapid reviews are your multi-agency process for reviewing different incidents. So if something has involved multi-agencies, that is the process we can go through, and it's a referral process. So there's a whole referral form that you would need to fill out either for children's or adults that then goes to almost a panel to be reviewed if it meets certain criteria to need a rapid review, which could then lead on to a serious case review that Elise was talking about. So if anyone wants to know more about rapid reviews, please come and talk to me and I can try and help you navigate them and where the forms are kept and how you would fill those out. Do you want to add anything else? No. Fab. And I've just mentioned a bit about serious case reviews there. One thing I didn't mention, which I'd like to kind of clarify about my role, is I don't do safeguard investigations or inquiries. Those are not what I do. While I do sit on the adult MASH, I am not the person that will review those safeguarding forms. So I don't go into children's MASH, so I don't see when people put in the forms for children's MASH, and I don't see the forms you put into adult safeguarding unit because I don't do the investigation side. I'm very much separate from the safeguarding units, if you like. I am more here for HSC to make sure our staff know their safeguarding responsibility and are skilled and competent enough to carry those functions out. Just want to really clarify those points. And that's us, and that's done.
Thank you very much. Any questions for Jo and Elise?
Quick one, hopefully. Having worked as a family nurse and dealt with different cultures and how subjectivity might be a big aspect regarding it, when I was listening to the kind of training you provide, I was just wondering, do you take that in consideration, the cultural differences that we might have on Ireland, and when things might seem unusual to Western society perhaps, and not that much according to that person's beliefs and religion even?
So what we're also in the process of developing in the early stages is a course on intersectionality, which will also look at cultural diversity, and that is threaded throughout lots of our different training. So I in particular talk about my experiences as a social worker and in different roles that I've worked in. with some of the incidents that come in, it has been a very careful approach needed, because some of them have been culturally acceptable from the country of where they've kind of been raised themselves. But when they come here, we're saying actually that's not okay. So it needs the sensitivity to help them understand why we're saying that, but also the acceptance that parents are allowed to parent their child as they see fit within certain parameters. So we do talk about religion, we talk about race, we talk about racism, ethnic diversity, different cultural beliefs and practices. All of that is kind of woven through our courses, but again, intersectionality is one we're looking at as well.
Thank you.
I wanted to say, I was thinking when you were talking about the self-neglect task and finish group, really interesting, because I've only been in the finish role for just a year, and I've seen so much of it that it's really eye-opening about what's out there where you're not used to seeing it in your own home, in your own kind of personal life. And I think it'd be really useful to have that where the quality patient safety team fit in that. So I don't know if that's part of that kind of process, or if it could be useful to know what kind of our position is. Yeah.
I guess when HSC are looking at their elements, that's absolutely what it is, yeah. But the task and finish at the moment is very multi-agency, with elements of HSC sitting on the task and finish as well. So I don't know where it's going to go, but it may be that HSC need to go away and think about their individual processes of what we do as an organisation. So yeah.
Thank you. Any other questions?
Yeah, hi. Neil Ray, Community Psychiatric Nurse for Elder Adults team. Do you have any, could anybody from care homes basically come and have training with yourself? Because it means paid training.
Yeah, they do.
They do, okay.
It's all free. So we work with Vanessa Penny, who goes out to care homes, and I've spoken about the training that we offer. Anyone can come on it at any point. We offer weekend courses, evening courses, and we're also trying to look at converting quite a bit of our more standard courses rather than the specialist to e-learning, to try and make it more applicable, more accessible to everybody. But yeah, everybody is welcome, and we do have quite a good contingent of people on our level 1 level 1 adults courses that come from care homes.
Okay, thank you.
Trying to encourage that more.
Any questions for them? Thanks very much, ladies. So next we've got John Eaton, who's our lead nurse for the acute wards and intensive care. Is that any others? Is that it? Just forward to skip forward and let's go back and just pop that on.
Have they got a break?
No, we'll just carry on, yeah.
Right. Afternoon, everyone. As Tammy kindly said, I'm John Eaton. I'm the lead nurse for acute inpatient wards and critical care. I've been in this role about 18 months, come on to 2 years, and I've spent most of my nursing career in critical care or intensive care here in Guernsey and in the NHS. So this talk is a rerun of a presentation Ruth and I have already delivered at an academic half day last year. So importantly, I wanted to keep Ruth on the credits because she did most of the work on this presentation, and I've rejiggled it to hopefully make it more applicable and generalise out. So not only have I got the last slot of the afternoon, but I've also got the cheerful subject of talking about dying patients and how we might choose not to treat them as fully as other patients. And we're calling this a treatment escalation plan or a limitation of care, ceiling of care. Now, we had a system in the adult acute bit of the health service across the car park there that essentially revolved around this sticker. And this sticker was put in the medical notes where the doctors write, and it couldn't be more simplistic to a fault. And the doctor who was responsible for a patient's care would work their way through this sticker, circling the things that they felt were appropriate in terms of escalation of care, so stepping up the level of treatment and intensity of that treatment for that patient. Often these stickers are used for patients who there's already been a decision not to resuscitate them, but there's a lot in between full active resuscitation and actively treating them up to the point of resuscitation. And this sticker was trying to capture that in a simple, easy to interpret way. And it didn't work for a number of reasons. Well, it didn't work very well, certainly from the nursing perspective. So I'll talk a little bit about that. Whilst we had the sticker, and we probably had the sticker for 5-6 years, maybe more, it was reflected in aspects of policy. We have bits of policy in the deteriorating patient procedure mainly, where it talks about mandatory triggers for a patient who may have their observations taken, and it triggers a score that suggests we need to escalate to a senior clinician. And there might be steps that would automatically happen within a nurse's remit in the absence of a doctor coming and reviewing and making a big treatment plan decision that would mean we would escalate care. And a lot of that should be automated for patients for whom it's appropriate, but it's not always appropriate for patients. There was an exception that reflected that we could not follow those automatic escalation processes for patients who had a written instruction that said it's okay not to start antibiotics, not to put them oxygen, not to rush them down the corridor to intensive care, where we could start sticking tubes and wires in that might be inappropriate and distressing, and ultimately not in the patient's best interest if recovery was unlikely. So, what was wrong with the stickers? I'm going to go back a bit. Oh, wrong button. I wasn't paying attention to my training, Tammy, about how to operate this. It's only got 3 buttons and I chose wrong. So, these stickers, they talk a lot about, are we resuscitating? How far we're going with the patient in terms of which department we might treat them in. And if we expect them to die imminently in this hospital episode. They didn't really say anything about what the patient's wishes were, and they only made a vague reference to whether the relatives were aware of the decision being made. They also got stuck in a paper file that might be that thick, and you might write 4 sides of A4 a day, and they would get lost in the raft of paper that we wade through every day. And the patient might go home and come back and go home and come back, and you'd never find this sticker again. So what we found, we're having lots of confusing messages on these stickers, lots of stickers that we couldn't find, and lots of ambiguity around what the stickers actually meant when they were completed, because they're open to making contradictory instructions. Okay, and this isn't good medical practice. Good medical practice talks about how important it is for patients to be involved in decision making and advanced care planning towards the end of their lives. It also talks about the importance of sharing these instructions and treatment plans and care plans with the teams in healthcare. And whilst these decisions are often instigated and led by a lead consultant, they also, I think we're About to get an interruption from someone with a high-vis jacket on. We need a communication tool that means that nurses, physios, OTs, healthcare professionals that all wrap around a patient's care in an acute hospital all have a shared and common understanding about what the intended goals are of that patient. So a typical medical patient will have a lead consultant, and that lead consultant will probably see them Monday to Friday once a day, but they're going to be looked after by other doctors at the weekend and overnight, and in a 130 bedded hospital it's not possible to give the level of handover to teams as you rotate through that 24-hour shift pattern. And the stickers fell short of the good practice here. So we had some ideas, we had a little working group, we had some ideas about what we wanted to change, but we knew our changes weren't going to be necessarily popular. So we thought we'd best do our homework first, and we did a couple of audits. The first audit, we had our CSCs, our clinical site coordinators, audit the medical notes of the patients that they reviewed out of hours. So this is where a senior nurse with some advanced assessment skills would be called by a nurse on the ward and asked to come and see a patient who had deteriorated in some way. And the clinical site coordinator wouldn't necessarily know the background and the history of that patient, and they'd have to interpret the written medical notes with all the clarity of beautiful doctor's handwriting and try and glean from what they'd written and work out whether we should do X, Y and Z to help this patient, or whether doing X, Y and Z would be inappropriate. So the CSCs audited a number of records for patients that they were called to see. Only 54% of the patients that they reviewed had a sticker. That might be okay. That's probably shows there's not enough stickers and not enough of these treatment plans being made. Less than 50% of the stickers that they did find were fully completed. Now, let's flip back again if I can find the right button. That isn't an onerous document to complete. It'll take about 10 seconds. The thinking should take longer, but actually completing it fully shouldn't be hard, and yet still we weren't fully completing these stickers in about 50%. A third of the cases, the sticker didn't correlate with the written plan in the medical notes. So the plan had moved, and patients' treatment plans move and change, and that's all fine and appropriate often, but you're then left with a situation with two contradictory instructions. Which one do you follow? You're not sure, so if in doubt you treat them because it's too late to do it the other way round, or you wake the doctor up, and you wake the doctor up who doesn't necessarily know the patient and their background and the complexities of their treatment plan, because it's the on-call doctor, not the doctor that knows them best. And most of the CSCs felt the stickers weren't at all useful. So we confirmed we had a problem. We also had a bunch of incidents where we identified some SIs in the mix, where we identified there was a theme where nurses felt uncomfortable escalating concerns to senior clinicians, and I'm broadening that out now to be senior nurses, clinical site coordinators, resus teams, and our medical colleagues and the doctors. So we did a broad survey around this, and we wanted to try and understand the attitudes and those behavioural and systems barriers to a nurse, recognising that something wasn't quite right with Mrs. LePage in the bed, but for whatever reason not doing what they should do in raising an alarm bell to their nurse in charge, to the site coordinator, to the resus team. And this survey wasn't good. It was a well responded to survey, but it left lots for us to worry about. 30% weren't always clear about how to escalate concerns. 79% experienced negative attitudes when escalating concerns. 29% would escalate the concerns, but they would experience anxiety. these, I'm not going to read these out, but I'll just leave these on the screen for you to read. And these are a sample of some of the qualitative responses we had to this survey. The part of the need to phone somebody and escalate a concern, or potentially part of the motive for being a bit grumpy, being a little resistant to receiving that phone call, is when, if you take the doctor's perspective or the senior nurse's perspective, is if the concern is being raised inappropriately and you're tired and you've got 100 other things to do. Naturally, you might then be less patient and less tolerant of that phone call if you perceive that phone call as not being important. But what leads that junior nurse to making that phone call is that they don't know whether it's important or not, but they know that something's wrong. And that led us to support this theory that the escalation stickers and what's written in the medical notes often isn't clear about what is an appropriate escalation and what's appropriate concern to raise. There's some more there for you to mull over. There's also a reluctance, an understandable reluctance, to make these treatment escalation decisions because they're heavy, they're complicated, they have long-lasting implications, and you can't make them lightly. And to be fair to our senior consultants who are making these decisions, they are very weighty decisions and they have ultimate accountability for them. So we do have to acknowledge that and understand that as primarily nurses in this case, the issues and barriers to them necessarily having these conversations and making these decisions with all the patients. But I think if you've managed to read that from the back, these comments aren't good and don't speak to good team working. So we had our audit data twofold, and it all supported the fact that we needed to do something. So we formed a little working group, representatives from our Dr. Copeland is a geriatrician, Judith is our resus officer, Liz Dorry and Laura Arblaster and Becky Bilton work in the palliative care team. So they had both resus and palliative care. We're trying to approach this problem from both angles. We had the clinical site coordinators and other senior nurses in this working group. And we developed, we agreed we needed to develop a treatment escalation plan, a more comprehensive document that addressed these issues around messaging and clarity of treatment plans. We looked to some NHS resources, as we all do. We see what we can plagiarise first. And the big document, the pinnacle really is this RESPECT document. This is something developed by the Resus Council UK. It's copyrighted. It's a big comprehensive document that covers every aspect of end-of-life decision planning and treatment limitations. We had previously looked at RESPECT and we'd done a sort of scoping exercise on it and considered whether we could implement this in Guernsey, and I think we would all like to. I think there's significant barriers to us managing it. So Judith and Neil Robinson, one of the ED doctors, went and visited the site in Salisbury and they looked about their implementation of RESPECT and came and fed back to QDC and senior management team. And whilst we want to get there ultimately, we didn't feel we had the resources or we were in a position to move forward with that at the time for whatever reason. So RESPECT was off the table, but we wanted to look at some of the principles of it and try and move forward in a pragmatic way. So we looked at some other NHS policies and we developed this treatment escalation plan. It's 2 sides of A4. We spent a lot of time thinking about formatting and how it could stand out and where it sits in the notes and all these practical systems things that the stickers didn't address because they got lost on a page. And we wanted to incorporate the things that were missing from the escalation stickers. So you won't be able to see this easily on the screen, but I'll just walk you through it briefly. This top section here is the consultant's initial indication for considering a treatment escalation plan, and that might be frailty, that might be a progressive incurable illness, and that might be because the patient is already not for resuscitation, but we haven't captured that other bit of their care. And then this section here is broadly trying to capture what the patient wants. So often patients have ideas about what level of treatment they want, what level of intervention they want, but they can't articulate it, or that doesn't marry with our interpretations as healthcare professionals about what's appropriate or realistic. So we wanted to capture both viewpoints and try and meet somewhere in the middle. And that included this kind of summary section for patients to think about life-prolonging treatment. They would want life-prolonging treatment, they would want to prioritise comfort and dignity, or they might want a little bit of both. So they might want active treatment, but up to a point. And then this bottom section here is really what replaced the sticker. This is the nitty-gritty of the detail of what we want. And we divided it into sections, and the red section represents full intensive care treatment, and the blue section represents treatment that you might have on the ward or you might choose not to have. And this might be things like introducing another round of antibiotics in someone with a recurrent resistant infection. This might include artificial feeding or giving them a blood transfusion. And this really allowed a bespoke yes, no, this isn't appropriate, which often covered most of the situations on the wards at 3 o'clock in the morning when there was uncertainty around, should I phone the doctor, should I start this treatment, is it appropriate or not? And then the back side of the page talks about capacity, powers of attorney, and what we've communicated with the relatives and how we've communicated it. And then there's a review section, and we also embedded an evaluation form. So we placed some key criteria around this. We had to do something practical and something manageable within our own sphere of influence. So whilst we might have wanted to extend it to community care settings, to the Oberland's long-term wards here and care homes in the private sector, none of that we felt was within our gift, and we were, if we tried to bite that, chunk of cake as well, we probably wouldn't have succeeded with the project, because we're heading towards the Respect whole Holland-wide kind of plan that we'd already ruled out earlier in the process. It was an add-on to DNA CPR forms, so it didn't replace that formal document that we're all probably familiar with. We'd have it in the front of the medical notes, so it was accessible through across episodes. We'd allow the TEP to remain valid across episodes, but also introduce the option for that being reviewed and revalidated, so it didn't automatically carry over. We wanted to focus on the patient's understanding and expectations, and also emphasise that collaborative, realistic decision making. And primarily, and this is how we tried to sell it to our colleagues who were asking to fill out 2 sides of A4 instead of a tick box sticker, was this was a communication tool that was going to aid everybody. It was going to reduce those nonsense phone calls, those phone calls that resulted in nurses getting stressed and anxious because doctors were being grumpy or surly with them, or they felt that the escalation was inappropriate or gone to the wrong team. And then we launched. No, we missed a step. We presented it to a collection of doctors, and at the academic half day where we first did this presentation, and we got some robust feedback, and we went away and considered that feedback and stopped sulking, and we made some changes and some adjustments, and then we pushed ahead. So we launched it in mid-October. We ran it for 6 to 8 weeks. We looked at 2 points of review. So we had an embedded evaluation survey It didn't come on the slide, but we put a QR code on with our electronic form, so users of the form could give feedback about how useful they felt it was. And we also planned to do a quality audit on how well the document was completed at certain points. So by December, we've been running it for 6 to 8 weeks, and we did our first pause and review. And we had to recognise some limitations in the process. So compliance and engagement wasn't great. We'd started with a rough launch. We made some concessions, but pushed on anyway. The inevitable perception that the form was more complex than what it replaced, the sticker. But we knew that, and it had to be more complex, otherwise it wasn't going to solve the problems that we thought needed solving. What the document never addressed was the training and confidence issues with doctors having these difficult conversations with patients and families. And in all fairness, we never expected it to fix that problem, and that wasn't within our scope or our sphere of influence, but it's a problem nonetheless, and it does need addressing. And part of our group included the palliative care doctors, who were very keen to try and push forward with this aspect of the problem. Yeah, and the form is only as good as the conversation, so that really just summarises. You can tick the boxes on the sticker, you can squiggle through the form, but if the conversation with the patient isn't of a good quality and those plans aren't agreed collaboratively with patients and relatives, then the decision's always going to be open to challenge. Okay, oh yeah, that's the timeline I talked through. So after December, we made some changes based on the feedback we received. We ran the second iteration of the form for another 8 weeks. We've recently paused and reviewed the feedback again, and we were hoping to finalise the document, but we have identified some more changes where we hope it will improve compliance on recording the patient wishes. We've introduced some different phrasing, different formatting to try and help facilitate these conversations and the way they're recorded. So we're running our third phase of review and evaluating the form. We've got an outline policy written and ready to go, but we want to finalise the content of the form and then tie the two things together and get the policy ratified. Questions, Fix?
I have a really quick one.
Go for it.
PEH-wise, is
Yeah.
it Alderney as well?
No.
No, purely PEH at the moment.
Purely PEH, and that was really a tactical decision about how many stakeholders we could win over and who we had some degree of influence over. We would like to think in the future we would extend this to the wards that are managed by the GPs, up in the continuing care wards, the Overlands wards up here, the HSC care homes and extra care housing, and Alderney as an outlying hospital. But that was, yeah, too big a problem for us to start with. Thank you. Jenny.
You've talked about the different strategies that you have tried to put in place to actually persuade people from coming from one sticker they weren't already completing to a two-page form, which is a huge challenge, as we all know, unfortunately. And you've talked about the different stages where you have assessed how they were complying with this, along with other aspects. Once the policy is ratified and that is officially in place, do you have a plan for an ongoing assessment of how effective this process is actually being?
Yeah, we need to do periodic audits of the quality of completion. That will probably go through phases where everyone gets used to it and improves, and everyone slips back into you know, our natural habits for taking shortcuts and skipping details. Don't have that clearly defined yet, but yeah, we absolutely agree it needs some sort of rolling evaluation, like every written document, and ultimately we'd like to see it put onto our electronic healthcare record, so that would help that and future audit.
Good, thank you.
I was going to ask if you plan on doing a staff survey afterwards to see how they're feeling about accessing help.
Yes, in some respects that was separate. It gave us some evidence to help justify the case for change here, but it was also broader, and I think that needs repeating in its own rights, but not specifically about the TEPs, because I think, you know, all those barriers and professional behaviours and attitudes, there was lots of training invested last year around civility between professionals, and, you know, that's all part of that problem. And this was just one. It just gave us another argument for change.
It's good to then understand how the people that are doing the work on the ground are actually finding, you know, how they access people and what response they get, and that they're being listened to, and that they, you know, if they are having problems, that you know, kind of feel they're being listened to and do something about it.
Well, it's that kind of thing, like sort of if you know, sort of if they're getting behaviours like that when they're escalating something that serious, it's not going to encourage them, you know, sort of when they're like sort of actually you haven't signed this prescription chart, you're not going to feel then confident
Absolutely.
to even go to somebody with something like that. So you can see how the errors and the things can easily start creeping
Absolutely,
in.
it's the thin end of the wedge, isn't it?
When you fed this back to the MSG at the academy, what was their perception of those comments? Did they have any feedback from it?
There was feedback, yes. Yeah.
Not to be recorded.
Yeah, I probably couldn't fairly
But they
present it or repeat it. There was acknowledgement. It was taken seriously amongst some groups. There was challenge and pushback on it, and part of that challenge and pushback is around work pressures, complexity of on-call rotas, the ability of, let's say if I'm generalising, nurses to make appropriate escalations and articulate their concerns in a concise and understandable manner. And all of those things are fair, and we are part of the system and the process struggles that we work in without junior doctors, with consultants doing 24, 36-hour shifts in some cases, depending on the team and the rota. These are all pressures, and if, you know, we're all human, and we'll all get grumpy and communicate poorly from time to time.
John, as someone who's experienced a very hot ear on the telephone at 3:30 in the morning, do you feel that the staff now, the nursing staff, have the ability to be clear and concise? Are we following an SBAR approach to assessment of our particular patients? And if not, how could we implement that?
So, sometimes, and to a degree, I think it's the only answers I can give, and I mean, it varies, doesn't it? Nurse experience, setting, team, time of day, yeah, it certainly could be better, without a doubt. How we could get there, it's a message. I mean, SBAR is well embedded now in all types of resource training and communication training. You know, 7, 8, 10 years ago, there was various tools being used in disparate pockets, and I think we've got a consistency and acute certainly around using SBAR as a structured communication tool. I don't think it's always used as effectively as it could be, and I don't know how. I don't have any clever ideas about how to make that better beyond more training and more, you know. Yeah, absolutely. Yeah.
Any thoughts on that?
Yeah.
Thank you very much, John.
Thank you, Tammy.
So we have run a bit over, but it was interesting to kind of capture those last few questions anyway. Thanks all for coming, and I hope that seeing people from different service areas has kind of given a bit of food for thought of anything that might be transferable to your own areas, or anything that you just were pleased to learn about, because there's lots of different things going on that we don't know about. If there is anything that you want to kind of showcase from your area that you've been doing, then please let me know on tammy.bugays@gov.gg, and we'll see you at the next sessions. And thank you to all our speakers.